Hello, everybody. My name is Andrew Wilson. I am a physician scientist at the Center for Regenerative Medicine. Good afternoon. It's my pleasure to get to moderate the third session of our symposium today. If session one was largely focused on AI and session two was more focused on stem cells and regenerative medicine, this session is now going to try to incorporate thematic elements of both of those, and the title of the session is AI and Regenerative Medicine. And we have three wonderful speakers to hear from today, and I have the pleasure of introducing the first. This is going to be a talk from Dr. Kayhan Batmanghelich. Dr. Batmanghelich is an assistant professor joining us from University of Pittsburgh from the Department of Biomedical Informatics and Intelligent Systems. Dr. Batmanghelich is also adjunct faculty at the Machine Learning Department at Carnegie Mellon, and his research focuses on the intersection of medical vision, imaging, electronic health records, machine learning, and bioinformatics. His talk today is entitled Auditing Breast Cancer Screening Risk AI Models for Hidden Biases Using Multimodal Large Language Models. Please join me in welcoming Dr. Batmanghelich.
Good afternoon, everybody. Thank you very much for the invitation and the opportunity. So today I'm going to talk about the research that we have done to use this multimodal large language models as a powerful AI models to auditing breast cancer screening AI models, as if one AI model audit the other one. And I want to thank the center, the Hariri Center and Ivan Institute for supporting our project. So I'm sure many of you have used many of these small chat boxes in your research or your work. And over the past few years, we have witnessed a flurry of a startup that have developed to use this model in the context of health, ranging from note-taking in clinic all the way to helping clinicians and patients in treatment planning. So nowadays, these LLM models, large language model, which is an example of the generative model, can translate from any language to another language, and even from human language to computer language, which means coding. So in the context of health, we have started seeing application of this model, for example, as assistant between clinicians and doctors. Many of the patients, for example, in clinic, especially when the doctors start talking about the treatment planning, feel lost in translation, especially with the medical jargons. Then there have been products that have developed that can help translate the terminology in clinic for the patients. But this doesn't need to be translation from one human language to another human language. In fact, it can be translation from pixels to human language. To give you an example, one of the works of the radiologist in a clinic is to read and interpret medical images. And nowadays, with the invention of the multimodal large language model, the field started developing models that can read medical images and generate something similar to radiology reports. As a person that has been working in this field for last 10 years, I've been asked this question that would there be any days that AI model can replace radiologists? The short answer to that is no. But I really like this comment by Curtis Langsos, which is the head of radiology department at Stanford, that he was asked this question and said radiologists who use AI will replace the AI radiologists that they don't. And the title of the talk today is about really collaboration between AI and radiologists. That's what I'm going to talk about today. More specifically, I'm going to focus on use of AI as a tool for predicting forward risk of the breast cancer screening as one of the most important cancer in female. There has been several AI models developed that can predict the 1 year, 2 year, and up to 5 years forward risk of the patient developing cancer. And it has been quite important. There has been several studies, including clinical trial in the past few years, that have shown that using this AI model can substantially increase the detection of the cancer patients. Predicting the forward risk model is quite important because, for example, if someone's test comes negative, you can use this to prioritize which patient should come to the scanner more often. However, many of the AI models are quite brittle. So let me give you an example. In a pneumothorax, which is collapse of the lung, it's very common practice, for example, to place a tube to maintain the negative pressure of the lung, either to replace the fluid or make sure that the lung does not collapse. So one of the phenomena that has been reported, for example, is that like sometimes this AI model may focus on presence of the tube and equate that with the presence of the disease, which is a risk for the patient for which the tube is not inserted yet. There has been several reports in the literature that, for example, AI model can focus on the color of the skin as a surrogate for a disease, and as a result may result in a biased model. Another phenomenon which is very important is a phenomenon called model aging. So model aging is referred to the phenomenon that the accuracy of the AI model degrades over time. To give you an example, let's assume that you have developed an AI model for detection of the COVID from the CT images. From the time that has developed, the population may change. For example, new variant may show up that manifests differently in the CT lung. The patient itself can change. For example, a patient can start smoking, the result in change in the lung of the patient. And sometime over time, a hospital may acquire new scanner that manifest different, they make the images slightly differently. And all of these can contribute in the degradation of the AI performance. But it is very difficult to find because you need some sort of like a code agent that monitor the behavior of another AI model and look for this kind of behavior, for example, degradation of the performance of the AI models. And in fact, there are plenty of opportunities like this in the pipeline of AI training. For example, a model that is developed specifically for this breast cancer screening developed in MGH, which has a different population than the BMC, which is serving mostly, which is a community hospital with a different population. The patient, through the time of the scanning, during the screening process may change. For example, one may have, might be before pregnancy or after pregnancy, can result in changing the test data and many others. The scanner can change at some point. The scanner of, for example, BMC and MGH might be different. And all in all, just before even we feed things to the AI model, some of the AI model may prune to learning some of the spurious features, some may not. Fortunately, many of these events leave some text trace into the data. For example, in the example that I told you earlier, the procedure note in EHR, electronic health record, mentioned the insertion of the chest tube. And in fact, if you look at the population, like we can look at the zip code of also like a insurance information of the patient population and gather what kind of population is served by the hospital. Individual informations are meticulously recorded in electronic health record, and all of the medical data come with very rich information in their metadata, for example, the DICOM of the CT images. And we and many other groups have developed a model that can translate internal mechanism of AI model into a text. However, finding a bias is finding a needle in the haystack. To add to that, there is also something called knowledge gap. So let me give you an example. AI scientists that develop models are really good at decoding and developing these models. Radiologists have a really good insight about the data. But when the explanation comes back from the model, it's very hard for computer scientists to even imagine what to look for the presence of the bias. And similarly for radiologists, it is very difficult, even after finding bias, how to patch the model and fix the behavior. So as a result, the general framework that we are proposing here is to collect all of these traces of the text in a form of perhaps sometimes unstructured text and pass them to different variants of a large language model, where the large language model swift to reduce a large amount of data and come up with a set of hypotheses for the reason for the structured mistake. For example, it can come up with the fact that, for example, in the subpopulation with certain properties, the model does not perform well. And these can be passed through a radiologist as a final check, and the radiologist can bring the feedback back to the large language model, and large language model can patch the model. And this is a feedback loop as a radiologist in the loop. So there are multiple challenges to address for this problem. We should be able to explain the data. We should be able, for example, to read the mammography images and produce something similar to radiology report. We should be able to explain the model. Internal mechanism of those should be able to convert it to the text so that it can be consumed by LLM. And we have to have a large language model can reason about the mistakes. I won't go through the detail of it, but we have developed a specific model for this purpose. And this is similar structure as a ChatGPT. It's using architecture, so-called neural network architecture using transformer. And with the way that we train it in a self-supervised fashion, because we want to have a generic model that can identify any sources of the bias. So we didn't want to train it for a specific task. And this is called like self-supervised training. We also have been trained a very special, like a training recipe, knowing the context of the disease. For example, the fact that the radiology report of the mammography has a specific structure, has a specific format, and also we also have to accommodate like some variation in the reports. So we won't go through the detail of that. And the data set is combination of the data set from my previous institution in UPMC, and some from Georgia, and some from Boston University. And we are currently working further with a much larger data set from University of Columbia. So let me give you some details. As I mentioned, this model is trained in a self-supervised fashion, which means that it's not trained specifically for one task, but we want to be able, this model, to detect anything that is all related to the breast cancer in a so-called self-supervised fashion. The model is able to detect 1 year presence, 1 year incidence of the breast cancer with a very high accuracy, close to the state of the art. It can also detect things like calcification, presence of the mass, and density quite accurately, although it's not trained. So now the next step is to use this model for breast cancer, for auditing breast cancer screening. Currently, the models that are used commonly in clinic, they're all demographic AI risk models. So none of these will use mammography images itself. Up until very few years ago, that MGH developed a breast cancer screening model, but there has been some concern that perhaps the population that this model is trained on, which is a population of the patient MGH, might be different from BU. So we thought that this is a great opportunity that we can use this model to audit this model, so-called MIRAI, that is developed by MGH. So to give you an example of how this model works, let me go back to the example I gave you earlier. The patient informations are in electronic health record that can be viewed as a text. We have a set of the patient for which the model is making mistake, and for some of those that the model does not make a mistake. The information about those images are encoded, for example, DICOM images, and can be converted to text. And using the model that I just told you, we can convert the internal mechanism of the AI into a text again and feed all of them to the large language model. So as an example, the large language model come up with a set of hypotheses. For example, presence of the chest tube may induce bias in the performance of the AI. Let me summarize the talk. So the hidden knowledges in this large language model can help us to audit this AI model that otherwise would be very difficult for only a single type of scientist, for example, AI scientist or only radiologist. Each of the components of the model on its own are quite useful. For example, if you are being able to explain the model like what I mentioned earlier, on its own can be a really powerful triage tool that reduces the workload of the radiologist. I did not talk about the fact-checking of the LLM because LLM can also sometimes hallucinate. We have developed tools over last year that can produce like a sentence-level confidence that can be translated for radiologists for further tests. And our ultimate goal is to develop an agent that can continuously poke this AI model and for changes that may happen in the healthcare system. Finally, I would like to thank my students and collaborators that make this project happen and funding it. Thank you very much.
Great talk. I'm just curious about the last part where you're probing the underlying model again and again. I just want to like understand like what would be the computational cost of this when you're doing it over and over again. I know it's going to make it better, but at what cost?
Yeah, actually, the cost of sending the text token to the large language model is not very expensive. We have a manuscript under review that we place the dollar amount of doing this, and it is below $1,000. We want to have an exact number. The entire experiment of the paper, by the way, not even a single model.
I had a somewhat more pragmatic question. Could you say a little bit about de-identifying images? I know you can remove embedded identifiers, but isn't the image itself identifying?
So all of these images have gone through the very rigorous de-identification process. There are RSNA tools standard for de-identification, and there are even commercial tools for de-identification of the radiology images. So nowadays, the de-identification of the medical images have a numerous standard tools for de-identification. I'm happy to introduce some because I've developed these kind of like tools from UPMC and use it quite a lot, so I know cognitive.
Hi, thanks for your talk. I was wondering if you're concerned about the LLM having its own biases. So you touched on hallucinations, but there are kind of other biases as well.
Yeah, that's very interesting point. So if you look at, for example, this generated report, I don't know if you have noticed or not. If you look at the age of the patients, the age of the patient here is not correct. It's basically the age of the patient is hallucinated. So I didn't go through how you can avoid the hallucination in a large language model. There are several methods that if you know the type of the mistake that LLM can make, so there are specific methods based on reinforcement learning that can basically penalize those kind of behavior. In addition to that, we have developed a method that provides sentence level like basically confidence, because at the end of the day, we want to have a radiologist in the loop. We don't want radiologists to read the entire thing. We want to only look at the sentences that are not like very confident. And in fact, this is the whole field is quite large. The general idea here is that you train your large language model on such a diverse data set that some of the effect of this specific supervised model are washed out, but yet there might be still some bias left. But there is always like, this is why we don't want to replace this, like radiologists that always look at the hypothesis.